publications for critical care. He went to medical school at the Keck School of Medicine, USC, took his residency in the same location in internal medicine, and then he was fellowship trained in nephrology from the same location, and then came to join us and is an assistant professor of medicine and continues to be active in the nephrology department. And he has many different peer-reviewed publications and presentations to his credit. One thing that is very noticeable when you see him coming around the hospital is he has his ultrasound in tow, which to me is a wonderful thing. I've learned from him. It adds some, not to criticize someone that doesn't do that, but it adds credence to his assessment and opinions regarding the day-to-day status of patients, and we all appreciate his input. I'm going to let you, if you choose, to mention your special connection to sodium if you choose. But welcome, Dr. Kaptein. Thank you.
Thank you for those kind words. Let's see, I like to keep it pretty informal. So if anybody has any questions in the chat, Dr. McCluskey, please just let me know they're there and we'll interrupt and we'll address them. And that way we can try to answer them instead of having you think about that for the rest of the presentation while I move on. For today's presentation, as much as I would love to talk about things like volume assessment, I'm going to consider that part as read. And we're going to talk about plans. How to make appropriate fluid therapies, so to speak, to optimize the patient's intravascular volume and the sodium concentration. And I will say that I think I'm presenting to a mixture of medicine and surgery critical care. This all comes from my striving for years to try to reconcile what I learned in surgery and surgical ICU with what I was taught in renal physiology, because I figured that it all had to make sense and blend somehow, but putting that puzzle together took a long time. I almost feel bad that I'm not going to present you guys with any new information. There's nothing cutting edge here, but perhaps the way that it's put together might change the way that you see things and might even hopefully change clinical practice. So I give a version of this to people at many different levels of training, and hopefully this is appropriate for this level of training. Here's sort of our objectives, what we're going to do, and some of these objectives are numbered in the slides just to help you keep track. So we're going to talk about a classic cartoon that diagrams the compartments into which the body divides the water, so to speak. We're going to talk about how we can use that model to better take care of our patients. A common practice, at least among my medicine colleagues, is to use things like the net fluid balance. And I'm just going to suggest that that is an invalid methodology, because on the face of it, I think that every single one of us here knows that blood is not the same thing as water, and that neither of those is the same thing as something like saline or LR. And so just adding all of those things together and considering them as somehow equal is just a false practice on the face of it. And then conversely, with body fluid outputs, treating them as if they're all the same as each other and all the same as a magical input, that's just also, so adding all these things that are different up and then subtracting, it's just not even close to valid methodology. And so that's for one day. And then when you decide to take that sum or difference and sum it over many days, the so-called cumulative fluid balance over a period of time, well, that's just cumulative junk. And as much as we all know that, papers get published using this methodology, and many people still think in those terms. Another thing that people look at is the total body weight. And the problem with the total body weight is, again, it doesn't differentiate what's, say, in the intravascular space versus what's in the intracellular space, or what's in the third space, and what might be fat and muscle versus edema, different ways to talk about it. And so total body weight is quite limited as well. And as if that weren't enough, the total body weight and the cumulative fluid balance, they don't actually tend to correlate with each other, and this has been shown. So these are the fundamental problems with these methodologies, not to mention there are additional practical problems that add inaccuracies. So going back, I found out that there was a surgeon named Henry Randall who published in 1952, who is one of the most uncredited people in the medical school curriculum, because he is the one who actually gives the data for the healthy 70-kilo man that allows us to draw this cartoon that I was presented with first in renal physiology, that shows basically how the total body water is divided into compartments in the body. About 2/3 in the intracellular, about 1/3 in the extracellular, and of that 1/3 of extracellular fluid volume, about 1/4 of that is in the plasma. So we can redraw that cartoon this way. You know, the joke when you talk to the renal physiologist is you say, well, what about the water inside a red blood cell? Not that there's a whole lot, but they would say that's intracellular. But we all know that when you give red blood cells to a patient, that expands the volume more than anything else. And that's because unless the patient is actually bleeding, the red blood cells don't extravasate. Whereas if you give the patient a lot of saline, the patient will later become swollen. And that's because that saline doesn't all stay inside of the cells. Some of it goes into the extracellular, extravascular compartment, the so-called third space. But the cells themselves, they have this sodium-potassium co-transporter that's trying to basically kick almost all the sodium out of the cells and almost all the potassium into the cells. And so the salt water, so to speak, can only go into the salt water spaces. It can't go inside the cells because the sodium doesn't stay inside the cells and the water follows the osmoles. And then in contrast, free water, basically things like D5, they can go anywhere, including inside the cells, assuming that the patient has functioning insulin and receptors. So, you know, hypovolemia or hypervolemia tends to generally reflect a total body sodium excess or deficit, whereas the free water, which can go inside the cells, mainly affects the sodium concentration. And I'm going to make an argument later on that the free water contribution to the volume status is actually negligible. And where I get that from is that they did these Everest trials where they were trying to use the Vaptan medicines to treat patients who had congestive heart failure and also hyponatremia, because they thought, well, they'll pee more, they'll lose weight, we'll fix the hyponatremia, and everyone will be happy. And I find humor in reading these papers, actually, because if you read the methods and results section, they almost look like they come from a paper that's totally divorced from how they try to sell it in the abstract and the discussion. But what you'll find on a careful reading is that the patients did indeed pee more. They did indeed lose weight. But the problem is that they didn't affect mortality and things like hospital readmissions. And the problem is that they peed out free water. So they didn't actually unload the space they intended to unload, is my interpretation. And they proved with a millions of dollars randomized, multi-center, double-blind, placebo-controlled trial what I could only hypothesize. So the free water gains and losses really are going to be reflected in hypernatremia or hyponatremia. And they won't really affect the volume status very much. So a preview of things to come. This is how a starter. It's kind of an idea. A patient, especially an ICU patient, can present with any disturbance of volume status combined with any disturbance of the sodium concentration. And these are some kind of starter strategies for how you can manage that to deal with the problems in all of the combinations that they might arise. Okay, so let's go back to something that I might have alluded to, but it's worth repeating. So you give a liter of 0.9% saline. How much of that is actually going to stay intravascular, say 24 hours after administration, after there's been time to equilibrate? And I don't really have a formal method for taking responses in this remote environment, so I'll just give you a minute to think about that. But basically the answer is that after equilibration, really how much saline stays in versus extravasates is really relative to the size of these buckets. And since this bucket is 3 times bigger than this bucket, about 3/4 goes out and 1/4 stays in. So about 1/4 of your liter will stay in after re-equilibration. Okay, but then what happens if you have a superedematous patient? Well, the ironic thing is that that means that this space is relatively larger. So actually, more than 3/4 of your liter will leak out, and less than 1/4 of your liter will remain in. And that's simply because now you've changed the relative size of the buckets because you have a severely edematous patient. So there's going to be more third space. Okay, so when is it reasonable to give something like LR or saline or isolite or plasmolite, something like that? That's going to be for your hypovolemic patient. Anytime you have a hypovolemic patient, volume expansion with an isonatremic solution is a reasonable starting plan. And that's regardless of whether they're hyponatremic, hypernatremic, or have a normal sodium concentration. Okay, moving on to our next basic example. How would a liter of D5W distribute? And I kind of gave you the answer anyways, but we'll take a moment to reflect. Okay, so that water, assuming again that insulin is functioning, can go into all of the compartments of the body. So it can distribute inside the ICF, inside the third space, inside the plasma volume, and the ICF is the biggest one. And so if you want to follow the model strictly, you might say, okay, well, 1/12 of that liter still stays in the intravascular space after reequilibration, or about 83 mLs. But I'm going to suggest that it makes the math easier and it's clinically reasonable that you can also make an even simpler approximation and just say, look, the water does not contribute to volume overload. You can really consider the intravascular contribution of free water administration to be negligible or 0. Okay, so when is it reasonable to give free water? Well, patients who have a normal plasma sodium concentration who can't drink water, for example, they need maintenance water. And patients who are hypernatremic, they actually have a lack of water. And so they need some water to catch up in addition to the maintenance water. So if your patient has normal plasma concentration or hypernatremia, giving them some water, not a bad plan. Okay. Let's flex this concept one step further. What if you have a liter of half NS? Well, I'm going to give you a basic physics strategy. Break it into components. So 1 liter of half NS is going to behave exactly the same as if you had given half a liter of NS and half a liter of D5W. Okay. And so then, if you want to use your approximation number 2, you can say that, well, about 1/8 of that liter will actually stay intravascular after reequilibration, because it would have been 1/4 of a liter for a liter of saline, but now it's 1/4 of half a liter of saline. So it's 1/8 of a liter that stays in, approximately, after reequilibration. Okay, so when's it reasonable to give half NS? Well, you wouldn't want to give it to a hypervolemic patient because it has, some saline in it. You might worsen their volume overload. You wouldn't want to give it to a hyponatremic patient because that patient already has a free water excess. So you don't want to give them extra free water, which is about half of the volume. So other cases, those are the times when it might be reasonable to give half NS as a fluid. Oh, and by the way, I'll just say that if your patient has working kidneys, many times you can get away with giving whatever fluid you want and the kidneys will pick up the slack. But when you have to pick up the phone and call me, well, then you have to proceed a little bit more carefully. Let's remind ourselves again that hypervolemia and hypovolemia, that's really ruled by things like blood products, crystalloids, colloids, and that has to do with the volume status of the patient, the sodium content of the inputs and the outputs. Whereas the hypernatremia, that really is reflected in the serum, or hypo, it's reflected in the serum sodium concentration, free water excess or deficit. And that's ruled by the free water content of outputs and inputs. Okay. So talking about inputs, you just check the sodium concentration for each solution. You may have to do a lot of very annoying unit conversions. You divide whatever sodium concentration you have by the 154, and then you have one proportion that is going to distribute like water, and the other proportion that's going to distribute like saline or another isonatremic solution. So you can break anything down into components, not just half NS. And so here's a publication where we kind of show how that can go. And this is really just sort of a lookup. Your formulary may vary a little bit, but this is a summary of many things that you can give to a patient, either enterally or parenterally. And again, these are not all the same. So adding them all up together in the total inputs and outputs and pretending like that means something is really fooling yourself. Going back again to Henry Randall for another nice quote, you have to pay attention not only to the amount, but the type of liquids which are required to maintain a fluid balance. And Dr. Randall is one of the few people who has actually published data to support what are insensible losses. And so he publishes that it's about 800 to a liter a day, and that the composition is about 93% water. There are some other sources that say otherwise, but I've never been able to track down the data that they use for their assertion. This was very difficult. With the help of a research assistant in a project with my mother back when I was a fellow, we were almost banned from the library, but we strove to look up what was the data for the sodium concentration of body fluid outputs in humans, all of the body fluid outputs. And this is a table that we can present to you, summarized from over 7,000 articles before we finally truly lost count. But there are some highlights here. I will say that things like peritoneal dialysis ultrafiltrate or hemodialysis ultrafiltrate, these are ultrafiltrates of plasma. And so the sodium concentration of these solutions is very similar to the sodium concentration of plasma. And if it were any different, my understanding would be very broken. It also turns out that things like edema, ascites, pleural effusions, these are also ultrafiltrates of plasma. And so they have a sodium concentration that is very similar to that of plasma. We found the article later, so it didn't make it in time for this, but one for humans in serous wound fluid is also has a sodium concentration very similar to that of plasma. Diarrhea looks like it's all over the place, but it's pretty tight in terms of the concentrations if you break down by mechanism. And some of the dogmas that we were taught about GI fluid sodium concentrations just were not borne out by the data that we actually found. But this is here for your reference. It took a lot of work to make this. This is presenting the same data, but sort of in a different way, just giving you some ideas of proportions that would be reasonable for replacing these different body fluid outputs, how much saline versus water or a combination would be reasonable. And if all of that seems very complicated, what I will do is give you a shameless plug. We used to pass this around as an Excel spreadsheet, but now there's an online calculator you can use where you plug in all of the inputs and all of the outputs individually. And what it will give you is a sum total in water equivalent units and saline equivalent units so that you can see what your net water either excess or deficit is for the transaction of total inputs and outputs, as well as the net volume difference. Okay, so what can you do with this? Now you can actually assess the effect of a day's inputs and outputs on the intravascular volume and the sodium concentration by breaking things down into components and seeing which proportion is going to behave like saline and which is going to behave like water. And we'll go through a couple of examples. I'll show you again this little table because we're going to cover it. All right. First, just a little quick talk about hypernatremia and sort of an approach. Remember that if you have a super high glucose concentration, you may need to do a correction for hyperglycemia. It may be worth your time if you happen to have a blood gas as well to compare the sodium on the blood gas to the sodium in the metabolic panel. And we'll talk a little bit why on the next slide. It is reasonable to think about this. In the ICU, why is your patient hypernatremic? Play straight odds. In the ICU, patient's intubated or confused. It may be that they have lack of ready access to free water. They just can't drink water when they're thirsty. Otherwise, ambulatory patients are very good at drinking water when they're thirsty. And seeing hypernatremia in a clinic patient is actually pretty rare. So in an ambulatory person who's not confused, things like that, they're most likely to have some kind of diabetes insipidus. Maybe diarrhea, vomiting, where they can't tolerate PO intake, or they're having a lot of free water losses and diarrhea. Another very common culprit in the ICU would be acute hypertonic load. And you know, we have all these protocols for 3% saline, but almost no protocols at all ruling the 8.4% sodium bicarb. And so I can't tell you how many times I've seen patients' sodium concentration increase by 20 milliequivalents per liter in 12 hours because they were on a continuous 8.4% sodium bicarb drip. So I would like to throw a bone and say that acute hypertonic solute load is a rare cause in the ICU, but let's just say that that one comes up from time to time. All right, and when you decide what you're going to do about your patient who has hypernatremia, it's important to assess the patient's volume status for practical reasons, even if that may not give you the diagnosis. All right, let's go back to what I said a second ago. The nomenclature is terrible, but what we have replaced flame photometry with, which is either called an ion-specific or ion-selective electrode, the sodium concentration reading you get is dependent on how much protein and lipid is in the sample that is given, and you expect there to be about 9% protein and lipids. But sometimes that's low because you have a patient that's very malnourished, and then you may get a spuriously high sodium concentration that's a lab artifact, which you call pseudo-hypernatremia. And it's funny because they don't teach you about this one in medical school. They teach you pseudo-hyponatremia, even though that's pretty rare. This is pretty common in the ICU if you keep your eyes open for it. And what's funny is that the way that they measure the sodium concentration in a blood gas is different. It's something called an ion-sensitive electrode. And so that if you see a discrepancy there, that may be a hint. Now, I hear rumor that actually at the VA, they measure the sodium concentration even on the metabolic panel with an ion-sensitive electrode. And if that's the case, then you don't have to worry about this at the VA, but I have never practiced there. All right, let's take a little case. Just a little break, change the topic. So you have a 23-year-old man, he's brought into the ER, he had an acute head injury, he makes half a liter of urine per hour, and he has labs that look like this, including a sodium concentration of 160. So how do you treat someone like this? All right, and the answer is that he needs some antidiuretic hormone and water, because this is a man with a central DI. With a head injury, he's not making ADH, antidiuretic hormone, the same thing as AVP or arginine vasopressin. And when you don't make antidiuretic hormone, you diurese. And it might be more accurate to call it aquarese. You dump free water. And so the serum sodium concentration goes sky high. When you make half a liter of urine an hour, you're never going to be able to fix the problem which is mostly free water in that urine. You're never going to be able to give free water alone just to keep up with that. So you also have to give some antidiuretic hormone in the form of DDAVP. So let's remind ourselves, how does a liter of D5W distribute? The water goes into all the different compartments of the body, and so very little, if any, really stays intravascular. So if you have a hypernatremic patient, it doesn't matter if they're hypovolemic, euvolemic, or hypervolemic, you need to give them water. And I promise you, you will not overload your patient by giving them free water. A little diagnostic approach to hyponatremia, we measure the serum osmolality, but we estimate the serum tonicity. I hate this nomenclature, but sometimes people call tonicity effective osmolality. And the reason is that there are certain osmoles that will depress your freezing point, which you measure, but those osmoles can also go into the cells. And these are things like uremia and alcohols. And so remember, osmolality is what you measure, but tonicity is what you want. And so seeing as these are related but a little bit different, the classic three categories would go along this diagonal line, but realize that you can be hyperosmolar or isoosmolar even though you have a free water excess if you have, say, a patient whose kidneys don't work and they're uremic, or you have somebody who has recently ingested ethanol or other toxic alcohols, and there's a fair amount of that still in the serum. So remember, osmolality, not quite the same thing as tonicity. The hypoosmolar person is automatically hypotonic, though. You see these ones are blank, and that means that that flavor just doesn't exist. And this is probably the most common. And so to deal with the hypotonic hyponatremia, you move on to your different categories based on the volume status of the patient. And this is kind of the classic way that this is divided. And for the purposes of this presentation, I won't go beyond that. let's have another case. You've got a 43-year-old man. This actually happened to me a couple of months ago. He was a dialysis patient. He had a urologic procedure because there was a bladder mass found as part of his kidney transplant workup. And so this is what I pasted into the note as my assessment. It was almost a throwaway. He had a borderline hyponatremia. So I said, restrict his free water. Okay, but this patient was hypotensive post-procedure, even before dialysis. And so then I got this question from the resident in the secure chat, my attending thinks he's dehydrated. Would you be okay with giving 500 mLs of albumin? I saw in your note, you had a free water, you set a fluid restriction to 1 liter total. And I sort of smacked my head, but I realized it's also a perfect example. When people use words different ways, there's the opportunity for communication breakdown. So let's break this down, decompress it. Most oral intake is mostly hypotonic stuff. There's just not enough salt in things like Gatorade or Pedialyte or milk or your nutritional supplements. If you think of all of those as basically water, you'd be more correct than not. So what do you take in by mouth that doesn't count like water? Well, broth, soup broth, something really salty, or condiments, things like soy sauce, which is actually saltier than seawater, or mustard is actually pretty high sodium as well. But other than broth and some condiments, most oral intake is mostly hypotonic. So when you restrict somebody's oral intake, you're really mostly restricting their water intake. Okay, well, my attending thinks he's dehydrated. The way we use words. If I assess somebody to be hyponatremic, then that means that they probably have a free water excess. If somebody else says that somebody is dehydrated, that means that there's a lack of water in the body. And to my smart aleck brain, that would mean hypernatremic. But dehydrated is not the same thing as volume depleted. And the reason I sort of bug people like crazy for using inaccurate words is that wrong words sort of lead to wrong thoughts, which sort of lead to wrong treatment plans. So yes, the patient may very well be volume depleted, even though he's not dehydrated. And so restricting the oral intake, the water, really has nothing to do with whether you ought to give this patient volume resuscitation for hypovolemia. So basically, without expounding like I have for you guys, I say, yes, go ahead and give him, I guess, some albumin if you want. Let's see, is there a question or something like that?
Yeah, there is.
Okay, let's have it.
No, Matthew, I was just wondering, caught my eye post-op day 1 after TURBT. There's a known hyponatremia syndrome after TURBT that I would potentially want to make sure that I exclude first based on the irrigation solution that they used in the OR.
That's fair. But when their patient is anuric, it's sort of simple. Either the patient drank too much water or the doctor somehow put too much water into the patient, even if it's in an irrigation solution. And basically all you can do is dialyze them and try not to put more excessive water into them. But fair point. Okay. So to hyponatremia. Basically, everybody who's hyponatremic, regardless of their volume status, you're going to want to restrict their free water. And if they have ongoing free water losses, you don't want to replace those losses. But if they're hypovolemic, certainly volume expansion is called for. If they're hypervolemic, you may actually want to limit their sodium intakes as well. One other comment that I will make with the dialysis patients is that many people think that it's a good practice to put every dialysis patient on a 1.5 liter fluid restriction. But I will tell you that if you do the math and realize that what you take out with dialysis is an ultrafiltrate of plasma, every liter or every kilo of dialysis ultrafiltrate is going to have about 8 to 9 grams of sodium chloride in it, or about 3 to 3.5 grams of elemental sodium. And so you can't take it out over and over again unless it's in there in the first place. And when you realize that's how much sodium you're actually removing with dialysis, well, if you don't put the sodium into the body in the first place, and you don't drive the thirst, the water part actually takes care of itself automatically. So if a patient is not hyponatremic and they're on dialysis, I personally don't think there's any point in giving them any kind of a fluid restriction except for broth, which is actually really a sodium restriction. All right, moving on. Another little case or example, you have a man who presents with persistent diarrhea and lowish blood pressure with an orthostatic drop in blood pressure. And so what's the primary body fluid abnormality? I haven't given you any labs, but based on the vitals, I think we can say that he is probably, let's be careful with our words, volume depleted, not necessarily dehydrated. So what would you give to correct the volume depletion? And there's probably more than one reasonable answer, so they would throw this away as a test question, but for the point of exposition, to sort of answer the question that I asked, an isonatremic solution, something like lactated ringers would be reasonable. But if you wanted to say, you know, you've got a patient with diarrhea and you want to say that half NS with potassium chloride premixed into it is a reasonable replacement solution for diarrhea, I would say that in many cases, yes, you're correct. All right, so let's remind ourselves. This time we'll say it's LR, but any isonatremic solution, be it LR, plasmolite, isolite, is close enough to NS that for clinical purposes, if you treat it exactly the same as NS for the purposes of this discussion, close enough. So after reequilibration, about 1/4 of that LR is going to stay in, about 3/4 is going to leak out, just as if it were NS. And so again, a hypovolemic patient, that's somebody who you want to volume expand with an isonatremic solution every time, regardless of whether they're hyponatremic, hypernatremic, or have a normal plasma concentration of sodium. And to remind ourselves about 1 liter of half NS, you break it into components. It's exactly the same as half a liter of water, half a liter of NS. And you use it in these circumstances. Okay, one more. So you have a 42-year-old man, and he has congestive heart failure, and he has dyspnea and rales and distended neck veins, and he has lower extremity edema all the way up to the thighs. And he has a sodium concentration of 124. So the total body sodium content, not the sodium concentration, the total body sodium content, would that be normal, increased, or decreased? I'm going to tell you it's increased. The man has edema up to his thighs and JVD and rales and dyspnea. So he is volume overloaded. He has an excess of total body sodium. So is the total body water increased, decreased, or maybe normal? And this man, in addition to his excess total body sodium, actually has an excess of total body water. And that excess of water actually exceeds the sodium excess, such that the sodium concentration is still too low. Let's get our heads around that for a second. You know, the story that I tell to patients is when I'm trying to explain their hyponatremia is that the sodium concentration is, okay, say you're mixing pancake batter and you put too much water in the batter and your batter is going to be too thin. And then say you're being silly and you send that batter to the lab. You're going to get the answer, well, the concentration of all of your ingredients is too low. And that's what's happening with the sodium concentration. But in this case, the patient is super edematous. So I suppose the analogy would be that you made too big a batch and you tried to cram it into a patient where it didn't fit. So here the total body water content is there's an excess of total body water. And so how do you treat this? Well, you certainly don't want to give them any more water. They're hyponatremic. You certainly don't want to give them any more sodium. They're hypervolemic. But a diuretic, which makes you urinate out extra sodium and actually quite a bit of extra water as well, that would be reasonable. So out with the salt and water, don't put any more in. So loop diuretic, restrict sodium, restrict free water. Kind of a secret of life that I'm going to tell you is that at least as an initial estimate, a lot of patients who have advanced chronic kidney disease or severe, although non-oliguric, acute kidney injury, or high doses of loop diuretic or thiazide diuretic are going to have a urine sodium concentration that's pretty close to somewhere between 70 or 80. And if you divide 70 or 80 by 154, you're going to get something pretty close to 1/2. And so the sodium concentration of urine under a great many circumstances that I deal with is pretty close to treating that urine for volume purposes as if it's sort of half NS coming out of the body, at least as an initial estimate. And if you want to refine that estimate, then you can check a urine sodium concentration and divide by 154 and break down into components like you would do for the inputs. Okay, so you have a patient like we just presented, and you give them a high dose of diuretics, and he has a 2-liter urine output. Now I have 2 questions for you. The first is, what is the free water loss? And the second is, what is the sodium chloride loss? Okay. Well, remember, you made 2 liters of urine. The urine is kind of like half NS because the urine sodium concentration is probably between 70 and 80. So you lose about 1 liter of free water. And you lose about 9 grams of sodium chloride. Because this is not a trick question. 1 liter of 0.9% saline has 9 grams of sodium chloride. That's why they named it that way. Okay. Whew. So you have a hypervolemic hyponatremia. You want to restrict sodium. You want to restrict free water. A loop diuretic is actually very helpful for impairing the ability of the kidney to concentrate urine. And if you can't kick out super concentrated urine, it's harder for the kidney to keep free water on the blood side of the lumen. And you don't replace ongoing water losses. What I will say, though, is that a thiazide diuretic impairs the ability of the kidney to dilute the urine. And so thiazide diuretics very frequently make hyponatremia worse. Pro tip. Okay, so now I've seen this patient many times. This is somebody who's on the cardiology service. Sorry to poke fun there. He's volume overloaded, he has heart failure, he has hypernatremia, and say he has anemia, and he's being treated with a fluid restriction and diuretics. What's the most likely consequence? Well, remember, most of those oral liquids that you're restricting with your fluid restriction are mostly free water. So restricting these may actually make the hypernatremia worse, and it's not actually going to improve the heart failure. But the diuresis, that will improve the volume overload. So you fix one problem, but not another. Remember, and it makes sense this way, if you think in terms of fluids, you're going to go crazy. The patient's fluid overloaded, but I'm letting them take in fluid, But if you think, look, he's hypernatremic and he's hypervolemic. So he has a deficit of water and an excess of salt. And the plan is out with the salt and in with the water. Then maybe it kind of makes sense. And if you want to be fancy and use a thiazide diuretic, that might be helpful. But a loop diuretic and just replacing a little more free water would also be just fine. All right, here, because we're coming up on time, I'm going to do a little bit of hand waving. But if you followed our model and the packed red cells were glue and there was no liquid in them, you might say, oh, well, red cells should count 4 times as much as saline when they go into the intravascular space and don't extravasate after equilibration of saline, that is. What I will say, though, is that the red cells, they do come in some solution. It's a sodium citrate solution. Some citrate goes into the cells so that they don't clot in the bank, and some chloride comes out of the cells. So you can kind of think of them as sitting in a little pool of NS now. And the average hematocrit of red blood cell preparations can vary quite a bit depending on preparation. But if you want to go with an average, thinking of red cells as counting 2.8 times as much as saline in terms of their volume contribution after equilibration, you would be much more accurate than somebody who just looks at total I's and O's. And if you wanted to make the math a little simpler and say that red cells count 3 times as much as saline, you would still be much more accurate than somebody who looks at total I's and O's. And so let's do an example there. Whenever we do our ultrafiltration on a patient, when we do dialysis, you have to look at the dialysis note to see how much was the net that was removed. Because in a typical dialysis, say that we remove 2 liters net, what the machine actually does is takes out 2.3 liters, because at the very end, we flush the lines back in with saline, the so-called rinse back, because we don't want to worsen anemia. So we want to save some of those red blood cells. So we actually take out 2.3 liters of ultrafiltrate, put in 0.3 of saline, and call the net 2 liters. And that's actually valid because the sodium concentration of the dialysis ultrafiltrate is very similar to that of plasma because it's an ultrafiltrate of plasma. And the sodium concentration of saline is very similar to the concentration of the water of plasma in a normal patient, which is actually 154. Because remember that 9% protein and lipids. So that's valid. But many times you'll say you'll give a unit of red blood cells with your dialysis. And say a unit is another 320 to 350 mLs. And so the dialysis nurse will just take out another 300 or 350 or 320 to make up for the blood that went in. And they'll say, oh, that was, making up for the volume of the blood. Well, after equilibration, that's not quite going to be enough to make up for the unit of blood that you gave. So the question I pose to you is, how much ultrafiltrate is necessary to be sort of net volume even intravascularly on the transaction, allowing for reequilibration if you give a unit of red cells with your dialysis? Okay, they don't teach it to you this way, but it has to be. So if you want to think of 320 to 350, a unit of red cells is about 1/3 of a liter. Okay, and the red cells count 3 times more. Well, you got to take out about 1 liter with your dialysis ultrafiltrate to make up for about a unit of inputs. Whew, okay. Let's take it one step farther. Oh, sorry, so let me ask you one more question. And what would be the free water loss with the 1 liter of ultrafiltrate for dialysis? And the answer is that it's minimal because you've taken out something isonatremic to plasma. So you don't take out much free water with dialysis. Okay. Say now that you have the same setup, but instead of using a hemodialysis machine to remove volume, you're going to use diuretics. So how much urine output is necessary now to be net even intravascularly on this transaction when you give a unit of red cells? Well, remember that urine sodium concentration is only about half of the sodium concentration of dialysis ultrafiltrate. So you actually have to take out twice as much urine as you would have had to take out dialysis ultrafiltrate to remove the same amount of intravascular volume. So actually, to diurese off the volume of 1 unit of red cells, you got to take out 6 times as much, or double what you would have had to do in ultrafiltrate. So 2 liters of urine for 1 unit of red cells. And it kind of makes sense, even though they don't teach you that way. And so really, truly, nothing is new under the sun. And I remember reading somewhere that in the sort of ancient East Indian medical texts, they have this idea that, 1 drop of blood is like worth 40 drops of water, and 1 drop of semen is worth 40 drops of blood. And well, nothing is new. Anyways, so I'll just leave you again with these quotes that you have to pay attention to the amount and type of fluids that are required to maintain balance, and that it is very important to consider the distribution of water and the major fluid compartments in the body. And I'll leave you with a joke and some time for discussion.
I like it. Thank you for that good discussion. We do have time, fortunately, for some questions or comments. If people want to just jump right in, that's fine. Or if you want to raise your hand. Anyone have any questions or comments? While people are thinking of that, just a reminder, we record these sessions, these lectures, and they're available on the Critical Care website. And EEDS, the CME entity that helps Loma Linda track CME eligible content, they also are choosing many of our grand rounds to offer through their site as well. And I don't think we have it up yet, but it's the potential for the future will be you can get CME if you weren't able to attend this in the future. Please do fill out your evals. Dr. Infante, please.
Thank you, Dr. Kaptein, for this excellent review, as always. One very interesting case that you had was a patient with a severe episode of hyponatremia, which was corrected with CRT. So we use CRT with different purposes, but one of these purposes is electrolyte correction. Can you please share that experience?
Oh man, let me see if I can pull that for a screen share really quick, because I've got a poster on it hanging right outside of my hall. But well, without looking too hard for that, basically it's possible to either just add water to the CRT solution bags, or to pull out some CRT solution, a certain volume, and then add a certain volume of just sterile water back to the bags. And you can manipulate the sodium concentration of the dialysate solution that way. And basically, when you're doing CRT, in the absence of other influencing factors, you should pull the patient to have a sodium concentration in their serum that's the same as the sodium concentration of the CRT bath. And so you can actually control pretty tightly what the patient's serum sodium is going to go to and not exceed by manipulating CRT solutions that way. And that's a good, very controlled way to do it.
Dr. Nguyen.
Yes, Dr. Kaptein, thanks for the review. Very nice. I have a question on management. I hope I didn't miss your discussion, but in hypo and hypernatremia, there's that one formula that we use often to figure out how much fluid to replace, and it's based on the idea of how much will 1 liter of hypertonic or hypotonic relative hypertonic or hypotonic fluid to give, how much 1 liter will change the sodium concentration, either for hyponatremia or hypernatremia. You're familiar with that one single formula? So I use that often. How do you feel about that formula versus the more traditional or old classical technique of calculating free water to correct hypernatremia, and also calculating sodium deficit to correct hyponatremia?
Okay, so the formula that you're speaking of is kind of using this idea that, let me see if I can find a good cartoon.
Yeah, that formula actually was published in New England Journal, gosh, quite a number of years ago.
And the formula in and of itself is valid. The problem is that the model is limited. It assumes that basically you can stop time. But the problem is that in the ICU, the patient has ongoing inputs, medicines that are hanging, maybe volume administration that's happening. The patient has ongoing outputs, be it urine outputs or other excrement, or maybe outputs from drains and things like that. And so unfortunately, the patient is an open system with ongoing inputs and outputs, and you can't stop time. And so I find that in clinical practice, using that formula where you're going to estimate a sodium concentration change based on an administration, really the only times that that's really useful is if you're going to do a rapid and drastic change, like if you're going to administer some hypertonic saline right now, and you want to make an estimate of what is the sodium concentration change going to be in the near future. Otherwise, I think that what my strategy is personally is that you want to figure out as best as you can, what are the ongoing losses of a patient in terms of urine, stool, drains, things like that, because these are going to have to be accounted for in terms of ongoing losses of both sodium for volume repletion and water. And then you have to figure out, okay, well, that's the ongoing losses, and you put it into 2 categories. One is the insensible losses, where Dr. Randall gives us the data. And then one is the sensible losses, which you actually depend on the nurse giving you the I's and O flow sheet for. And so you try to sort of put ongoing losses in one category as best as you can estimate them. And then there is, what is the excess or deficit? And when there is an excess like water, even though there's a lot of guidelines for, how rapidly you ought to correct hyponatremia, when there's a free water excess, unless you have symptomatic hyponatremia where you're doing an infusion of hypertonic solution, really you just sort of restrict the free water and cross your fingers and pray, and hope that the correction rate is appropriate. And then when you're dealing with hypernatremia, it's actually a deficit of free water. And so there you have a lot of opportunities to make calculations. But as far as the guidelines go, all we know is that, well, in terms of overcorrection, we think that's what's good for hyponatremia is probably good for hypernatremia too. And that's kind of the extent of our guidance. There, the strategy that I like to do personally is that you take what's the deficit and then try to replace half of that deficit as well as all of the ongoing losses. Because the idea is if you sort of try to walk to the wall, but each time you only walk halfway to the wall, Zeno's paradox, will you ever get to the wall? Maybe not, but for clinical purposes, you will approach the maintenance free water gracefully if you iterate that process every single day. And then I'll just mention that there's also a third category, which is, hey, what are the inputs that that patient is getting anyways? Like maybe the heparin drip that we now run in half NS, even though we used to run it in D5W. And so, you know, you figure out, well, how much water do you have to give? How much water are you giving the patient anyways? How much water is the patient losing anyways? And then how much water do you have to give on top of that? Or, you know, and that's the problem with the open system, is that it just sort of smashes the assumptions that are necessary to employ that equation that you were referring to.
Yeah, it's interesting because I remember as a resident, you know, when that equation came out, and this is, gosh, you know, a number of years ago. And I remember and you know, back then, I mean, the idea of calculating deficit and replacing half of it now and then the other half later, I mean, that's been around for a while, I think. And the equation came along, and the idea was that equation will always consistently change the appropriate sodium, you know, as you progress. But you're right, as I found out when I use it, I find myself recalculating the rate after 1 liter. So every liter I put in, you know, after that liter, I recalculate my rate if I'm using the same concentration of the volume. So I'm still kind of at odds of which method is the best. But I mean, using the one formula, for me, it's easy to kind of explain or teach to the resident in a physiological way, and it applies both for hypo and hypernatremia.
Well,
so I don't know if that's practical enough, you know.
All the equations that we're talking about are actually based on the same fundamental underlying concept, and that is the conservation of matter. And they all are different rearrangements of the terms of basically concentration 1 times volume 1 equals concentration 2 times volume 2, which is exactly what you do in the lab when you're mixing reagents. And so whether you're talking about the sodium part of that or the water part of that, these are all different rearrangements of the same terms, and it's really different applications of the same concept. And the question is, are you going to treat the patient as if they're a closed system for a very short period of time and try to estimate the changes of a very rapid intervention? Or are you trying to make a longer term plan that you're going to execute over 24 hours? And then different strategies based on that same idea of conservation of matter you apply to each context.
Thank you. Is there any other comments or questions? I'm going to take advantage of this moment. This is more like a public service announcement. I'll ask either yourself or Dr. Infante to comment on a very separate topic, but pertinent to this audience. The idea of giving methylene blue to someone that's on CRRT and how that can adversely affect the CRRT machine utilization after the fact.
Okay, thank you for touching that topic, because we are receiving a little bit more information about what other methods are we using for refractory hypotension. And in one of the latest guidelines instruct to use hydroxycobalamin, in which in critical care it has become much more prevalent. It happens that hydroxycobalamin is a substance that is fairly cleared by the filter. But the problem is in that the machine senses as if this was hemolysis. So we, in our medical center, we have Fresenius dialysis machines in which the sensor is a colorimetric sensor, and that will preclude the patient to have the utilization of the Fresenius machine for intermittent hemodialysis or for prolonged intermittent renal replacement therapies, or SLED. So we are obligated to use our PrismaFlex or PrismaMax machines when we use hydroxycobalamin. So it is very, very important that I understand that the clinical decisions to use these substances are extremely valuable at the moment with a patient with vasoplasia. But we have also to understand that the limitations that this brings for dialysis in our institution.
Dr. Fuente?
Yes.
I'm sorry to interrupt you, but I have spoken with our charge nurse about this. And yes, there is an error that the intermittent dialysis machine will throw when you use something like hydroxycobalamin. However, it is possible in the heat of the moment to override that error. And there is a confirmatory test for hemolysis that the dialysis nurse can do in the meantime. And if that test is negative, and it will be if it's just hydroxycobalamin, then the treatment can actually continue with the intermittent hemodialysis machine. So yes, there is an error. Yes, it has to be overridden. Yes, a confirmatory test has to be done. But if the nurse understands the context and is sort of prepared for that to happen, smooth dialysis that's intermittent can be done in patients who have received hydroxycobalamin, and I have presided over that.
Oh, that's an excellent news. It is extremely important that we follow the policies and procedures for safety because I was told by one of the nurses that the alarms can be shut off, but that would not be appropriate. Anyway, it takes like 10 days for the hydroxycobalamin levels to be so low that are not detectable by the intermittent dialysis machines. So, so basically, that's the information about using CRT after hydroxycobalamin.
Thank you so much.
You actually reminded me something about CRT, though, if I may. That is very related to the presentation I just gave. I know that people often pay attention to the net balance when they're doing CRRT as well, and it's even baked into the way that we make our orders. But I will tell you that that net fluid balance on CRRT is as valid for CRRT as I suggest it is for the rest of critical care, which is not very. And so even though we torture our nurses, making them fill out this flow sheet, and we make our orders based on a net, I often clinically basically just consider that to be a giant fudge factor. And when I want to know what's actually going on, what I basically do is I look at the standard INO flow sheet that the critical care nurse will fill out regardless. And all inputs can be accounted for example, in this calculator, if you're not used to doing it that way in your head. And all of the different outputs can be accounted for in this calculator as well. And what comes out of the dialysis machine is standard dialysis ultrafiltrate, and that has a known or estimated sodium concentration. And so when I want to understand the net volume effect of what's happening to my CRRT patient, I actually completely ignore that flow sheet that calculates nets, and I interpret the standard ICU INO flow sheet, but in this manner, which may not be the way everybody else does it, but I think is actually the most valid. A sort of corollary is that most ICU patients are getting a combination of isonatremic inputs and hyponatremic inputs. And what we take out with the CRRT PrismaFlex machine and the intermittent machine is basically isonatremic or similar to NS. And so even though you, quote, keep even, you are on average slowly emptying these patients. Unless, of course, you give them red cells, which then throws a giant monkey wrench into that whole system. And then you really have to do something a little bit more accurate to figure out what's going on.
Okay, we are at the end of our time. This has been a great discussion. Again, remind everyone it has been recorded, so I'm sure there's colleagues that will be very interested. You can just spread the word. Dr. Kaptein's an excellent resource in person as well as the rest of your guys, the nephrology wonderful department. We really appreciate all the support we get from your department always. Thank you all for attending, and I wish you all a great day.